Welcome to a new episode of NeoMed AI Podcast, the podcast that offers insightful AI for better neonatal care. Today, we're tackling a topic that every neonatal clinician needs to master: Hypoxic-Ischemic Encephalopathy, or HIE. This is a time-critical neurological emergency where every minute counts.
That's right. Prompt recognition and management are absolutely key to improving outcomes.
So today, we're going to walk through it all using a single representative case to guide the discussion. We'll start with the fundamentals, move through the nuances of clinical management, and finally touch on some of the tough consultant-level challenges and ethical questions that can arise. But before we start with our case scenario, can you clarify for us what the precise definition of HIE is?
Of course, HIE is a specific type of neonatal encephalopathy, or NE. NE is a broader clinical syndrome we see in term or near-term babies where their neurological function is disturbed right after birth. They might have a low level of consciousness, seizures, or trouble with breathing and muscle tone. HIE is when we believe that encephalopathy was specifically caused by hypoxic ischemic insult, a lack of oxygen and blood flow to the brain around the time of birth. In the UK and other high-income countries, we see moderate to severe HIE in about 1 to 3 per 1,000 live births.
Got it. So let's dive right in with our first case scenario. Imagine this. A term male infant is born via emergency C-section for a cord prolapse. At birth, he's limp and apneic. His APGAR scores are poor, 3 at 1 minute, 4 at 5 minutes, and still only 5 at 10 minutes. He requires endotracheal intubation and ventilation, which is ongoing at 10 minutes of life. At 20 minutes old, a capillary blood gas shows a significant acidosis, with a pH of 6.95 and a base deficit of 18. He's now been transferred to the neonatal unit for assessment. Does he meet the criteria to be considered for the main treatment we have for HIE, therapeutic hypothermia?
Yes, he absolutely does. In the UK, our practice is guided by the criteria used in the big clinical trials, like the TOBY study. There are essentially 3 gates to get through: A, B, and C. He sails through the first 2. Criterion A is about the physiological measures. Our infant meets this in multiple ways. His APGAR score was less than 5 at 10 minutes, he needed continued resuscitation at 10 minutes, and his blood gas showed a severe metabolic acidosis within 60 minutes of birth.
And the second gate, criterion B?
That's the neurological exam. He has an altered level of consciousness, he requires intubation to breathe, and he was described as limp, which is hypotonia. This combination points to at least moderate encephalopathy, so he meets criterion B.
You mentioned a third gate, criterion C. What's that?
Criterion C is the use of amplitude integrated EEG, or AEEG. An abnormal background pattern, like burst suppression, or the presence of electrical seizures on the AEG, confirms significant encephalopathy and strengthens the case for cooling. However, and this is a key pitfall to avoid, if AEG isn't immediately available, its unavailability should not delay the decision to cool if the clinical picture is as clear as it is in this case.
So, we've decided to cool him. Why does this work? What's happening in the brain?
This is crucial. The brain injury in HIE happens in 2 phases. First, there's the primary energy failure from the initial lack of oxygen and ischemia, which causes some cellular necrosis. But then, hours later, typically 6 to 24 hours after the event, a secondary wave of injury can occur. This is driven by reperfusion injury, oxidative stress, inflammation, and a process of programmed cell death called apoptosis. Therapeutic hypothermia is aimed squarely at interrupting that secondary, delayed phase of injury. It's not a cure, but it's a break on that subsequent cascade.
That really explains why this is so time-sensitive. What is the therapeutic window we have to get that break applied?
The evidence is clear: cooling must be initiated within 6 hours of birth. The earlier you start, the better the chance of it working, because you're trying to get ahead of that secondary injury cascade.
How is that done in practice, especially if the baby needs to be transferred to a specialist center?
The treatment itself involves lowering the baby's core body temperature between 33 and 34 degrees Celsius for 72 hours, usually using a whole body cooling mattress. But while awaiting the transport team, the referring hospital must start passive cooling. This is as simple as turning off any overhead heaters and removing blankets, allowing the baby's temperature to drift down towards that therapeutic range. It's a vital first step that can be started immediately. One of the worst things you can do for an encephalopathic brain is allow it to get hypothermic or febrile, which significantly worsens outcomes.
In that stressful initial period, you're not just thinking about cooling. What other supportive care is critical?
Absolutely. You have to prevent any further secondary injury. This means meticulous attention to the basics. You need to maintain a patent airway and effective ventilation, but crucially, you must avoid hypocapnia, a low CO2 level which causes cerebral vasoconstriction and can worsen the injury. You need to support their cardiovascular function to maintain normal blood pressure and ensure good brain perfusion. And you have to maintain normoglycemia, as both high and low blood sugar can be harmful to the injured brain.
Let's move our case forward. The infant is now 4 hours old. He's on a cooling mattress, and his core temperature is 33.6 degrees Celsius. The AEEG has been started, and it shows a burst suppression pattern. Then, at 5 hours old, the nurse spots rhythmic, repetitive jerking of his right arm and leg. What's happening, and what's the immediate next step?
This is highly suspicious for clinical seizures, which are a very common complication and confirm a severe encephalopathy. The immediate next step is to use the real-time AEEG trace to confirm that these clinical events are true electrical seizures in the brain, and then to administer a first-line anticonvulsant.
What is the first-line drug of choice in UK practice?
That would be phenobarbital. A loading dose of 20 milligrams per kilogram is given intravenously over 20 minutes. It's important to remember that you might not see the full anticonvulsant effect for another 20 minutes after the infusion finishes, so you need to be patient before deciding it hasn't worked.
What if it doesn't work? If the seizures continue after 30 minutes, what's the next pharmacological step?
If the seizures persist, you can give 1 or 2 more doses of phenobarbital, for example 10 milligrams per dose, up to a total cumulative dose of 40 milligrams per kilogram. You have to watch very closely for side effects like respiratory depression and hypotension when using higher doses. If seizures are still refractory, you move to a second-line agent. In the UK, this is often phenytoin or increasingly levetiracetam, although the evidence base for levetiracetam is still emerging compared to phenytoin.
For our listeners in the trenches managing these babies, can you give us some key clinical pearls or common pitfalls to avoid during the 72 hours of cooling?
Absolutely. First, a practical pearl: always use a rectal temperature probe for accurate core temperature monitoring during both cooling and rewarming. A major pitfall is under-sedating the infant. Shivering and distress counteract the benefits of cooling, so ensure you have adequate analgesia and sedation on board, often with a low-dose morphine infusion. Another key point is seizure management. Don't mistake the sedative effect of phenobarbital for seizure control. You must use the AEEG to confirm that the electrographic seizures have stopped, as it's common for the physical jerking to stop while the brain is still seizing, a phenomenon called electroclinical dissociation.
That's a critical point. Does the cooling itself affect our monitoring tools? For instance, how does it change the prognostic value of the AEEG?
That's an excellent and subtle question. Yes, it does. Cooling itself is a cerebral suppressant, so it can make the infant appear more encephalopathic than they are, and it can delay the maturation of the AEEG background pattern. An abnormal AEG in the first 6 hours has a lower predictive value for an adverse outcome in a cooled baby compared to a non-cooled one. However, the key prognostic indicator is the trend. Failure of the AEEG background to improve or to recover a normal sleep-wake cycle by 48 to 72 hours remains a very strong predictor of a poor outcome.
Is the UK approach to HIE identical to practice elsewhere, say in North America?
It's broadly similar, but with some minor differences in emphasis. The eligibility criteria are almost identical across the UK, US, and Canada, using that same combination of perinatal history, physiology, and neurological exam. In the UK, we predominantly use whole-body calling, which was the method in the Toby study. Both whole-body and selective head calling are considered effective, but many centres prefer whole-body as it allows easier access for EEG electrodes. For anticonvulsants, phenobarbital is the universal first-line agent, but some European centres might use lidocaine more frequently as a second-line option than we do in the UK.
Now, a big part of managing HIE is prognostication. How and when do we use MRI to help with this?
Brain MRI is the most valuable tool we have to seeing the pattern and extent of injury. The ideal time to do it is between day 5 and day 14 of life. This window allows the injury patterns to fully evolve and be optimally visible. We look at specific sequences. Diffusion-weighted imaging, or DWI, is most sensitive for detecting the acute injury in the first few days, but we also need T1 and T2 sequences, which are better for showing the full extent of the tissue loss and damage in the second week. We can also use MR spectroscopy, which measures neuronal markers like the lactate to NAA ratio, adding further prognostic information.
And what patterns of injury are you looking for?
Broadly, there are two main patterns that have different prognostic implications. The first is injury predominantly to the deep gray matter, the basal ganglia and thalami. This is often from a sudden, profound insult, like the cord prolapse in our case, and it's strongly associated with adverse motor outcomes, particularly dyskinetic cerebral palsy. The second is a watershed or parasagittal pattern, which affects the border zones between the major cerebral arteries. This is more often associated with a prolonged partial hypoxia and is linked to cognitive problems and spastic quadriplegia.
This brings us to the most difficult part of the job. Let's escalate our case. The infant completes 72 hours of cooling and is slowly rewarmed. The MRI is done on day 7, and it's devastating. The report describes extensive, near-symmetrical injury to the bilateral basal ganglia, thalami, and perirolandic cortex, with a very abnormal lactate peak on spectroscopy. Clinically, the baby has no spontaneous breathing, absent brainstem reflexes, and no suck or gag reflex. The parents ask, "What does this mean for our son?" How do you even begin that conversation?
That is the hardest conversation in neonatology. It has to be done with incredible sensitivity, honesty, and clarity. You have to sit with the parents and explain that the MRI findings, combined with that devastating clinical exam and a severely suppressed EEG, carry an extremely poor prognosis. You have to explain that the parts of the brain responsible for movement, sensation, and even basic survival functions like breathing have been severely and irreversibly damaged. The likelihood of survival is low, and any survival would be with profound and universal neurodevelopmental disability, with a complete dependence on medical technology for every aspect of life. It's vital to state clearly and gently that recovery of the functions that are currently absent is not expected.
And when the discussion turns to whether it's appropriate to continue life-sustaining care, what's the ethical framework in the UK?
The guiding principle in the UK is the best interests of the infant. When treatment is considered to be futile or is causing more burden and suffering than benefit, it may not be in the child's best interests to continue it. The Royal College of Paediatrics and Child Health provides a clear framework for this. It's a collaborative process with the parents to ensure they understand the prognosis, and the focus of care shifts from curative intent to providing comfort and dignity. Getting a second independent consultant opinion is best practice, and the goal is always to reach a consensus with the family. Early involvement of the pediatric palliative care team can also be invaluable for both symptom management and family support.
That's a very clear explanation. To wrap up, let's run through a couple of quick-fire consultant-level scenarios. First, a transport team is delayed. Active cooling with a mattress isn't started until the infant is 7.5 hours old. The 6-hour window has been missed. Should you proceed?
This is a major deviation from standard practice because all the high-level evidence for benefit is based on starting within 6 hours. There's no evidence of benefit and a theoretical, although undefined, risk of harm when starting late. The decision has to be individualized. You must have a very frank discussion with the parents, explaining that the standard therapeutic window was missed and the potential benefit is unknown. Medico-legally, this is a clinical incident. It must be documented transparently, including the reasons for the delay and the shared decision-making process, and it must be formally reported and reviewed through local clinical governance systems to identify any system issues.
And final scenario, the parents of an infant with a devastating MRI bring you information they found online about stem cell therapy offered at a private clinic overseas. They ask if this is a viable option. How do you counsel them?
You have to start by acknowledging their search for hope and validating their desire to do anything possible for their child. You then have to state clearly and gently that stem cell therapy for HIE is entirely experimental. There is no scientific evidence from robust clinical trials to show that it is safe or effective for this condition. You should explain the risks of unproven therapies, including potential physical harm, the financial cost, and the burden of travel for a very fragile infant. It's about gently redirecting the conversation back to the known prognostic factors and focusing on ensuring their baby is comfortable and cared for according to the highest proven standards, which in this case would include palliative and comfort-focused care.
That's incredibly helpful advice. If you had to leave our listeners with just 2 or 3 key take-home messages from our entire discussion on HIE, what would they be?
I'd say there are 3. First, HIE is a time-critical emergency. Prompt recognition and getting cooling started within that 6-hour window is everything. Second, therapeutic hypothermia is a proven neuroprotective strategy that reduces death or major disability, but it is not a silver bullet. Many survivors still face significant challenges. And third, management is so much more than just the temperature on the machine. Meticulous, comprehensive supportive intensive care is absolutely fundamental to preventing further injury and giving that baby the best possible chance.
That's incredibly helpful advice. Perhaps a final thought for our listeners is to remember the long road these families face. We know from follow-up studies that even survivors without cerebral palsy are at a higher risk for hidden disabilities like cognitive difficulties, executive function deficits, and behavioral problems that may only become apparent at school age. A normal assessment at 2 years doesn't rule out later problems, so continued vigilance and support is essential.
And just a reminder, this AI-generated information is for educational purposes only and is intended for trained neonatal clinicians. It does not replace independent clinical judgment. Always refer to the current national and local guidelines.